Hi, I'm Stacy Hunter. I'm an OMS2 student and I go to Lincoln Memorial University, DeBusk College of Osteopathic Medicine. So I'm going to be talking about this is a four-part series, part one of four, and we'll be talking about the pelvis and the lower limbs. So I took a lot of these slides from a review that was made from a third year named Allie. So I just want to give her credit for most of these slides. Okay, so here is the pelvis osteology. I know that they don't really go over that in lab or lecture that much. So just come back and refer to these first two slides and you can see the osteology if you are don't know some of these parts. They could, put some or color code it or something and say, hey, what attaches here in lab. So just make sure you know where those parts are and what they're called. So we're going to be talking about the true and false pelvis. And so the false pelvis is going to be the ilium, but things below that, like ischium and pubis, as well as our sacrum coccyx, that's going to be our true pelvis. And I'll show you what I mean. So here's some more osteology. So right here is our false pelvis. So this is not actually our pelvis. It's higher than our pelvis, but right here below this, where we get into the sacrum, below our L5, that's going to be our true pelvis. That consists of the pubis and ischium, also our sacrum, the urinary and reproductive organs, and it's bounded by that pelvic inlet and outlet. So into it is this pelvic inlet and coming out is that pelvic outlet. So the peritoneum is what anchors the roots to our external genitalia, and it's going to contain the openings of our GI and UG tracts. So let's talk more about that. So if we look at our pelvises, there's going to be a difference between a male and a female. So a female has more of a circle-shaped pelvis inlet shape. So as you can see right here, it's more of a circle shape. But here with a man, it's more of a heart shape. That's our pelvic inlet. And it's important to know these differences between these two. So the subpubic concavity, there is going to be one with a male, but there's not with a female. And then this pubic body width is going to be larger with a female. As you can tell, it's smaller with a male. The greater sciatic notch is also going to be larger with a female, but smaller with a male. And then, and this is the concavity. I didn't really talk about that, but see how you can see how it's concave, but it's not right here with a male. And then females, they're going to be more medially angled. So the femoral shaft is going to start moving more toward the middle. So that's called valgus. And when you learn about the lower limbs, you can understand what valgus versus varus is. So valgus, a lot of people think of as like valgum. Like if you put gum between your knees, it's going to stick them together. So that's like in like lay terms is knock knees. So if somebody has a valgus, if their legs are valgus, that's going to have or knock knees, it's going to lead to more knee replacements because it's not even. So that's just something to consider. Also, there is a wider subpubic angle for females versus the males. Okay, so there's two really important pelvic ligaments that they love to like test on and ask about in lecture and lab. So we've got this greater sciatic foramen and we've got this lesser. And I color coded these ligaments and try to give you the borders of the greater sciatic foramen, like located right here in this picture, so it can kind of make sense, and that's what this diagram is. So we've got two sides of our greater sciatic foramen that is our ischium. So right here. And then we've also got this sacrotuberous ligament And as it goes down going across is the sacrospinous ligament. And that is attaching at our ischial spine, where the sacrotuberous ligament, it's coming right here from our sacrum going down to our ischial tuberosity. And so the lesser border, we're going to have a little bit of our ischium, sacrotuberous, and sacrospinous. So these two ligaments crossing help make up our greater and lesser sciatic foramen. And we're going to talk about the foramen, so don't worry. I just want you to know the difference between these two ligaments and know where they attach. Ischial spine versus ischial tuberosity. Okay, so we've got some pelvic joints as well. So maybe you've heard of the SI joints, and if you feel on your back below your L spine, as it starts getting down to our sacrum, you can sort of feel that indention where our SI joints are. So superiorly, we've got two zygapophyseal joints, and then these are synovial joints, and then there are intervertebral discs, which are fibrocartilaginous. I'm not the best at saying some of this stuff. Anterior, we've got the pubic symphysis right here. Posterior, like we had talked about, we've got our sacroiliac joints, which is synovial, and it's going to transmit that forces from the lower limb to our hip. And then at our hip joint, that is our acetabulo-femoral joint, which is ball and socket. Okay, pelvic osteology. So there's some spaces that we need to talk about. We've talked about the greater and lesser sciatic foramen, but it's important to know what comes in and out of it. So first off, we've got this pelvic inlet, which we've also talked about. Here's our greater, and here's our lesser sciatic foramen, and then here's our obturator foramen. So in our greater sciatic foramen, above piriformis, which we'll talk more about next week, that's a muscle, which is one of the lateral rotators. Above that, it's almost like a line that just crosses in the back, that everything above it is going to be superior gluteal nerve and vessels. Everything below piriformis is going to be inferior gluteal nerve and vessels. So when we're talking about our gluteus muscles, that'll start making more sense. So below this piriformis, we've also got our sciatic nerve coming down. Important, don't cut that in lab by accident. It's really big, can't miss it. You've also got the posterior femoral cutaneous, and then the nerve to quadratus femoris coming out of that greater sciatic foramen below piriformis. Our lesser sciatic foramen is going to have our internal pudendal nerve and also our nerve to obturator externus. Our obturator foramen is just like the name of it. It's going to have our obturator nerve and vessels. And we've already talked about the ligaments sacrospinous and sacrotuberous, but both of them prevent the upward tilting of our sacrum. And they're labeled in this diagram too so that you can see them. Okay, so there's some different types of pelvic fractures. And you can, sometimes it's easier for me to just be able to look at a picture and know what it kind of looks like. So there was a bunch of slides on this, so this is all one slide, so it makes it easier. So maybe this person has some chronic pain, leg length discrepancy, sexual dysfunction, or nerve palsy because of one of these pelvic fractures. So the force for a lateral compression is going to be lateral posterior. The potential sites of fracture is going to be on our sacrum. It doesn't really show a fracture here, but it could be our sacrum. Also our acetabulum, and then also the PSIS. There's going to be instability, which is going to be rotational as well as vertical, which makes sense. And then the characteristics are going to be, it's going to be like a ipsilateral SI joint or SI ligament injury. Okay. The anterior posterior compression. So if you kind of think about it, like if you're pushing anterior and posterior together, it's going to like crack in the front and back. So we are going to, it's called an open book. So potential fracture sites are going to be that pubic symphysis as well as our SI joint. Again, it's rotational and vertical. So there might be some neurovascular injury as well as mortality associated with this. And it makes sense that there's a neurovascular injury because there's a lot of nerves and vessels that are going like through these locations. Okay, vertical shear. It's going to be through the femur or the ischial tuberosity and potentially fracture the ischial spine. It's usually going to be unilateral. There's some other fractures as well. There's that isolated iliac fracture. Lateral compression doesn't affect the anterior pelvic ring. Acetabular fracture, it's going to be transmitted through the femoral head or the trochanter. So like you would see this with some major trauma, like if a pedestrian is hit or like in the elderly, because their bones are more fragile. Also a straddle fracture, that's going to affect the pubic and ischial rami. It's going to be anterior compression. So it's like where the gas tank of a motorcycle would be, like if you sit on one. And then, but there's no posterior fractures. And then there's also some like isolated ramus fractures, and that's probably going to be in the elderly. Okay, so now we're getting to the pelvic muscles. So we've got a pelvic diaphragm and then a UG diaphragm or urogenital diaphragm. Both of these are going to be innervated by the pudendal nerve. The pelvic diaphragm consists of our levator ani muscles as well as our coccygeus. So here's our levator ani, and right here is our coccygeus. Our coccygeus, if we look at this right here, we'll start with this one. There is a ligament right here that's going from our sacrum all the way right here to our ischial spine. So that is going to be our sacrospinous ligament. Sacrum to spine, sacrospinous. Coccygeus sits right on top of it, and that it's going to be actually fused to the sacrospinous ligament. Okay, so our levator ani. So here's our anus, so that's where we get ani from. Puborectalis is going to be, it's right here. It's right around the rectum and anus. It's like a sling. And you can see it better in this picture when you just see it from this direction. So if this sling is weak, it's going to be causing fecal incontinence. So we're going to start losing feces. So the person is going to present with having going to the bathroom on themselves, and they didn't realize it. The pubococcygeus, that's going to be our next muscle, and that is, it may tear during childbirth, as well as the superficial transverse peritoneal muscle. That's another one that may tear. And then our iliococcygeus is the one that's on the outside, and that's going to be closer to our ilium. So I think of like puborectalis, it's closer to our rectum. Iliococcygeus is going to be closer to the ilium, and then right in the middle is going to be pubococcygeus. So the peritoneal body, it's going to be right here in the middle. That is where it's going to be a joining of the sphincter of the urethra and the deep transverse peritoneal muscles from our deep space. We'll talk about our spaces in a little bit, as well as our bulbospongiosis and superficial transverse peritoneal muscles, as well as our external anal sphincters and our levator ani fibers. So it's like everything from these triangles are sort of just joining up and they're meeting right in the middle at the peritoneal body. And you'll find that in lab. Okay, here are some of the fascias, and then we're going to end up talking about it again. This is from first aid, and I really like this. I know it was in your lecture. I really like how they lay out different things. So I know that you may not be ready, I'm still not really ready for board studying, but sometimes if you can't understand it from one perspective, I think it's important to look at it maybe from another perspective. And sometimes I like things just summed up. It makes more sense for me. So then when I look at all the material, I understand it better and I can kind of organize it better. So all of these ligaments and where they connect to and what structures and then some fun facts about them are all located in first aid. So that may be like a resource that maybe you've not utilized but may help you. We're going to talk about each one of these on different slides. The only one I don't really think that we're going to be talking about is the first two, so we're going to talk about them right now. So the infungio-pelvic ligament is going to be from our ovaries to the lateral pelvic wall. So let's see, do we have, that one's not labeled in our picture. It's going to contain our ovarian vessels. It's also called that suspensory ligament of the ovary. And that may be where you actually hear it more often. And so when they do a oophorectomy, they are going to ligate those vessels. Okay, the cardinal ligament is the ligament from the cervix right here. And it's going to go out to the side walls of the pelvis. And it's going to contain the uterine vessels. During a hysterectomy, there might be the ureter, since it's traveling right here. When they're ligating the uterine vessels, they might accidentally nip a ureter. So that might be a problem. It says it's not shown in the diagram, but this is a different diagram, so it is shown right here. Okay, here's some more ligaments. I thought this was a better picture. So here's the ligament of the ovary right here. And it's connecting the uterus to the ovary. The round ligament, it is connecting the uterus to the labia majora. The uterosacral ligament, as you probably guessed, it's going to the sacrum, and it's going from the cervix to the sacrum. And then the transverse cardinal ligament that we had talked about is right here. So these are like easy things that they could just tag in lab and then say, what is this? So just know the differences between these ligaments. I know there's a bunch. And then it's something that they could like add in a question during the lecture. Okay. It's really important to know what is deep, what is superficial, and knowing like all of these layers and their spaces. So I remember learning this and just going on my whiteboard and like saying, okay, top of my whiteboard's deep, lower part is superficial, go, and see if I could label them. And that really helped me like sort of get it. Okay, so the deep layer. Now, the other thing to remember is you're kind of like looking, it's like if the person is standing is the way that this is going. So the things that are deep are going to be like inside of them, where something that's superficial is going to be like on the outside, like toward the genitalia. So like don't get confused, because it's pretty easy to do that. Okay, so the deep is going to start with our superficial fascia of the the superior fascia of the UG diaphragm. And so that's right here in this picture. Then we're going to have the deep peritoneal space, and that is going to contain our bulbourethral glands, which is our Cowper's glands, and then also our external urethral sphincter, and then our deep transverse peritoneal muscles. And then we're going to go through like the rest of this stuff. So our inferior fascia of the UG diaphragm, which is also the peritoneal membrane, is going to be the next layer. So in between, so we've got superior fascia, and then we have inferior fascia, and then we're going to have superficial fascia. So between the inferior fascia and the superficial fascia is going to be our superficial peritoneal space. That's going to be the crura or bulb of the clitoris or penis. It's also going to be the greater vestibular glands or Bartholian glands. It's also going to be bulbospongiosus and ischiocavernosus, as well as the superficial transverse peritoneal muscles. So the superficial peritoneal fascia is also called Colles fascia. So let's look at each one of these. So Camper's fascia that we had talked about from last block, that's that fatty layer. It's going to become that superior fascia of the UG diaphragm, the Dartos fascia. Then we've got our Buck's fascia, and this is only in males. It's going to be the peritoneal membrane, which is anchored to the base of the glans penis, continuous with the posteriorly with a suspensory ligament of the penis. And then our Scarpa's fascia, which is membranous. Remember, we camp out scarp in. That is going to become Colles fascia, the fascia lata, and the pubic symphysis. And we're going to talk more about Colles fascia. Okay, so we just looked at our deep peritoneal space, so now we're going to go more into detail about that. So we said that it was consistent of our bulbourethral glands, our Cowper's glands, and then our external urethral sphincter and our deep transverse peritoneal muscles, in between our superior fascia and our inferior fascia. So we've got our bulbourethral glands, that deep transverse peritoneal muscle, and then that external urethral sphincter, or sphincter urethrae, which helps with our urinary continence. So that external sphincter is what we control. So like, I've got to go to the bathroom. Like when you feel that pressure, you don't automatically just start peeing. You have control over it. So even though your brain says, my bladder's full, I need to go, you're able to contract that external urethral sphincter in order to make it all the way to a bathroom. And then when you let that go, that's voluntary control, and that's then you're able to urinate. So if you do not have control over that external urethral sphincter, then you're going to be incontinent of urine. Right here near our urethra is the bulbourethral gland, our Cowper glands. And here these are labeled. Okay. So we've got our superficial peritoneal space. So remember, if we look just a slide back, this is going to be the superficial space is in between the inferior fascia of the UG diaphragm and in between the superficial peritoneal fascia, or that Colles fascia. Okay. So this is going to consist of our crura of the penis or clitoris, the bulb of the penis or clitoris, and the greater vestibular glands, which is only in females. Also, it's going to consist of our bulbospongiosus muscle, ischiocavernosus muscle, and our superficial transverse peritoneal muscle. So here's our bulbospongiosus. And I think of it as like right here is the bulbs. So it's over, like it's over the bulbs. That's what this is right here. This. So it's laying right over it. Also, like the muscle itself kind of looks spongy. Here's our ischiocavernosus muscle near our ischium. Here it is on another page, looking at the male anatomy. And then this superficial transverse peritoneal muscle. It's superficial, it's going horizontal, so it's transverse. Here's the bulbospongiosus on males, and here's the superficial transverse peritoneal. So here is our triangle. Here's our greater vestibular glands located right here. Here's the crux of the clitoris. So it like comes around right here. And there's the crux of the penis. So they're very similar where everything's located. And here is the bulb in both of these. Okay. So this is also from first aid, and it's talking about urethral injury. So if we're looking at the superficial fascia, the membranous layer of this superficial fascia, remember we said was Colles fascia, it's located right here in our blue color, and it's going to be fused to the posterior margin of the peritoneal membrane, which is colored in green. So what happens is if somebody is hit anteriorly and it starts filling with blood starts accumulating in the scrotum, it's not going to go anywhere else because of this fascia located here. If Buck's fascia is torn, urine's going to start escaping into the peritoneal space. But if it's not torn, blood just accumulates here. If it's a posterior injury, most likely it's going to be due to like a pelvic fracture. There's going to be injury to the membranous urethra versus that bulbar urethra, and urine is going to leak into the retropubic space. So there's going to be like a high riding prostate. So if you can see right here, this is where the blood is located. So it's not all outside into the scrotum. It's going to be just like contained right here in the middle. And there's going to be torn part of this urethra. Okay, the sacral plexus. So this can be a little bit hard, but we'll get through it. So we're going to talk more about all of the like lateral rotators and everything, but they went ahead and introduced the sacral plexus, so we're going to go ahead and talk about it. This is a really pretty picture that labels out everything, but I'm going to go ahead and go to the next slide. If this really helps you, like, go for it. If my like cheat way of remembering things helps you, then go with that option. So this is the way I remember it, knowing what the nerve roots are, because like you're going to have to know what nerve, of course, innervates each of the muscles, but it's important to like also know what the nerve roots are. So the nerves of the sacral plexus are going to pass through the greater sciatic foramen. Okay, so SIPS is the way I remember this. So if you first write out, if you like get out a piece of paper and write it, it kind of makes more sense. So the first thing that I do is I write on a diagonal 1, 2, 3, 4, 5. The next step, I just back up one number and I go 4, 3, 2, 1, And then since there's not another number, I go back to 5. And then I do the same thing. 3, 2, 1, 5, 4. So what these represent is L4, L5, S1. So I start making lines. So I make a line up. I first make a line down. I make a dotted line that goes down between 4, 5, 1, 2, 3, and then the other 2 sets of numbers. And then I make a line up, and that goes across. So L4, L5, S1 will go with superior gluteal nerve. So I make these lines, and then I'm going to start labeling them with SIPs. So superior gluteal nerve, inferior gluteal nerve, nerve to piriformis, that's the P, pudendal nerve, and sciatic nerve. So L4, L5, S1 is superior gluteal. L5, S1, S2 is inferior gluteal. Nerve to piriformis is S1, S2, S3. Pudendal nerve is S2, S2, S3, S4 keeps the penis off the floor. That's the way of remembering that one. And then sciatic nerve, as you can tell, I didn't put a line down here. And I highlighted these because sciatic nerve is going to be L4, L5, S1, S2, S3. It's going to be this entire line. So if this doesn't make any sense, or like you're like, I need you to explain it, like draw it out with me, that's completely fine. Like message me, email me, whatever. Find me in person. And I can go back over this, like if it helps. But this is the way I remembered it. And then just like remembering that little mnemonic, S2, S3, S4 keeps the penis off the floor. And it's pudendal. Okay. And now we're going to talk about pudendal. So here's our pudendal nerve. It's going to come out, as we had said before, through the greater sciatic foramen and then enter back in through the lesser sciatic foramen. It's going to be traveling around that sacrospinous ligament. And so right here is where we've got that coming out and then going back in. And then this is also going to go through this pudendal, which is also called Adcock's canal. So right here is that Adcock's canal. And it's going to be within the fascia of the obturator internus muscle. It's going to be containing the internal pudendal artery and the vein and the nerve. So Adcock's canal, pudendal canal is containing internal pudendal artery, vein, and pudendal nerve. So there are branches of the pudendal nerve that you need to know. So if they say, what's innervated by this? And you put pudendal, like that may not be an option. I know as far as lab, they always want you to go with the most specific option. So if pudendal is on there, but then there's also like dorsal nerve of the penis, that's a more specific answer. It's a branch out of pudendal. So like you need to go with the most specific answer with whatever they label. Okay. So branches. So here we've got our pudendal nerve. We've got a branch that is coming right up here, which is the dorsal nerve of the clitoris or penis, giving sensation there. Then we've got posterior scrotal or labial. So that is going to be right here. Here's our posterior labial. Then we also have the peritoneal nerve, and it's going to give motor to the superficial and deep space muscles, as well as sensory to the peritoneum. And then inferior rectal, and it's going to be motor is going to be the external anal sphincter, and then sensory is going to be around the anus. So just know, and we had already talked about inferior rectal last block, so it's just a review kind of from it, but remember it's coming from the pudendal. So just be able to know what all of these branches off of pudendal are and where they go to. I mean, their name sort of tells what they're doing, where they go. Okay, so a pudendal nerve block, doctor will palpate the ischial spine and the sacrospinous ligament, and then administer an anesthetic where the nerve crosses the ischial spine. So this is during childbirth, so that the mom can bear down but not like feel pain. So here's this like picture showing you that. Okay, the anal wink test. So remember, we've got the anal right here. We've got this inferior rectal nerve coming from our pudendal nerve. So the anal wink test is the external anal sphincter is going to be contracting like when somebody pulls the penis. And so it's a bulbar cavernosus bulbospongiosus reflex, and it's also useful when evaluating impotence. Okay, so here again, I was just putting this review slide in here. Now that we've covered more things, here's where all of the things come in and out again. Okay, innervation. Again, S2, S3, S4 keeps the penis off the floor. And then also we've got sympathetic and parasympathetic. So let's just think again about what sympathetic and parasympathetic mean. I know that you had it last block. You're going to continue talking about sympathetics and parasympathetics. So sympathetics do vasoconstriction. So it's going to be our fight or flight. So we need our blood pressure to like start. We need it to go up when we're like running from a bear. We also need to have contraction of the internal urethral anal sphincters, because we don't need to like start peeing. And then also with parasympathetics, we're going to have vasodilation. So decreased blood pressure, because we don't need, and also we're going to have a decreased heart rate, because we don't need to like worry about a bear chasing us. We're just like hanging out, chilling on the couch. And so we can have a contraction of the bladder, which leads to urtication and defecation. So I use like SLUD, salivation, lacrimation, urination, defecation. So also, but what we really need to think about besides like the bladder would be ejaculation and erection. So the way of remembering this is point and shoot. So point, that's erection. That's going to be parasympathetic. Shoot is going to be sympathetic. So that's ejaculation. Okay. And then that like stage fright is a sympathetic problem. So these plexus, this is like one way of looking at it. I've got a diagram that shows you in a different manner. And this is the diagram that I drew out. So I think of like the abdominal aorta coming down. And then so we've got our common iliac. Remember, it branches into external and internal iliac. So in our like orange color, we've got our parasympathetics, and in our blue, we've got our sympathetics. And as you can tell, here's our sympathetic chain. And so we've got the thoracolumbar splanchnics that are going down to our superior hypogastric plexus. And so our hypogastric nerve, still sympathetic, they're going to be going down on both sides to our inferior hypogastric plexus. And our inferior hypogastric plexus is going to be both sympathetic and parasympathetic. And they're going to be going to our bladder, which is our vesicle, prostate, uterus and vagina, and then rectum as well. Parasympathetic inferior hypogastric plexus is parasympathetic, and the pelvic splanchnics from S2, S3, S4 are going to our inferior hypogastric plexus. And then our pudendal nerve, remember that is our S2, S3, S4, keeps the penis off the floor. Okay. So we've got some pelvic arteries. So our posterior trunk is pretty easy. We've got only 3 things. Iliolumbar, superior gluteal, which is between the lumbosacral trunk and S1, and then also lateral sacral. So remember when you're looking at it in lab that we're naming things not where it came from, but what it's going to. Then the anterior trunk. So the anterior internal iliac is going to have the umbilical, obturator, inferior vesicle, and uterine, internal pudendal, inferior gluteal, between our S2, S3, and then our middle rectal. Our umbilical is going to give off our superior vesicle. Remember, that's going to our bladder. And then our inferior vesicle goes to our ductus deferens, and that's only in males. And then in females, we've got our uterine, which is going to give off a branch to our vaginal. This is my drawing of all of the branches off of internal iliac. So remember, we've got common iliac, and then it's going to be branching into external and internal. So the external goes down in the leg to the femoral nerve, or femoral nerve, whatever way you say that. So our internal gives off an anterior and a posterior branch. I'm going to start with what they end with. So the posterior branch ends with superior gluteal, and that's coming between the lumbar plexus and our S1. And so I like to remember it as they're consonants. So superior and posterior both start with consonants, and then anterior and inferior both start with vowels. So I can remember which ones come off of which. And it's going to be inferior, so it's going to be lower. It's going to be between S2, S3. So remember where they come between and also what they come off of. So let's start with the posterior branch. We've got the iliolumbar. It's kind of going more upwards if you look in lab to that lumbar region, and I just sort of think of it going up. And we've got lateral sacral. So we've got one lumbar, and then we have a sacral, and then we have glutes. And that's the only thing that's coming off of the posterior branch. That lateral sacral is going between S1, S2. And then here is our superior gluteal. Our anterior branch, I start thinking, to know all of the branches, I kind of think about, okay, I'm going to start up top and sort of go down. So I'm starting at my belly button. I've got the umbilical artery, and that goes to make the median umbilical ligament. And that makes the median umbilical fold. It's giving off a branch, superior vestibular artery, and that goes to the superior portion of our bladder. Our next one is going with our obturator artery. That goes through the obturator foramen with the obturator nerve. And so it's really easy to distinguish between those two, and those are easy things that they could tag. So if you see it going between there, it's coming off of this anterior branch of the internal iliac, you know it's the artery versus the nerve, and it's a little shinier, the nerve is. The next one going down for females is going to be the uterine artery, and that gives off a vaginal artery branch. For men, they're going to have an inferior vesicular artery that's going to the lower portion of the bladder. And then they're going to also have a prosthetic branch that comes off of that inferior vesicular. Going on down, we've got our middle rectal, and then our internal pudendal artery, and ending with that inferior gluteal artery. So middle rectal, if you remember from last block, it's going to our rectum. Remember that superior rectal came off of IMA. The middle rectal right here comes off of this anterior iliac, internal iliac. And then that inferior came off of inferior pudendal, which we had just talked about. So here's another way of looking at it. So either chart or this might help you. Okay, so venous drainage. Let's first talk about the penis itself and look at all of the layers. So we start out, outermost layer is the skin. Our next layer is that superficial or dardos fascia. In this areolar tissue, it contains the superficial dorsal vein. So remember, that is the superficial dorsal vein is just deep to that dardos fascia, but it's superficial to right here, the next layer, which is our deep or our buccal fascia. Our right under our buccal fascia is going to be the deep dorsal vein, and then the dorsal artery and nerve. Inside that is going to have corpus cavernosum, which contains the deep artery, and then located in the corpus spongiosum is going to be the urethra. So be able to know like where these things are located. What you also need to know is where the veins drain into. So we talked about this superficial dorsal vein. That's going to be deep to our dardos. It's going to be draining the prepuce and the skin of the penis. It's draining up into our external iliac, where our deep dorsal vein, located under that buccal fascia, is going to be draining the erectile tissues, and it is going to be draining into that internal iliac. So just knowing deep goes with internal, and then this superficial is going with external. So the pelvic plexus drains the bladder, prostate, and rectum, and it's also going into internal iliac. And then we've got the pempiniform plexus, and that's draining our scrotum. So on the right, we've got it drains right into the right gonadal vein going to the IVC, but on the left, it's going to be draining into the left gonadal, into our left renal vein. And remember, from last block, you've got that important relationship where the left renal vein is going over to our left kidney, traveling over our aorta, and the superior mesenteric artery, if it gets enlarged, it can cause that nutcracker syndrome and clamp down on the left renal. Well, not only will blood accumulate in the kidney, but also blood can accumulate in that left scrotum as well. Okay, external genitalia. So the mons pubis is that fatty section over the pubic symphysis. The clitoris is the erectile tissue made up of the prepuce glands and crux, located right here. The vestibule is all of this space contained by the labia minora, and it contains the openings of the urethra, vagina, and vestibular glands. The labia majora is the fat, sebaceous glands and pubic hair on the outside. Labia minora is on the inside, containing the skin folds and some erectile tissue. The greater vestibular glands are going to be right here, containing mucus secreting glands on either side of the vestibule. The other name for it is Bartholian glands. And then the posterior commissure overlies that peritoneal body that we've talked about right here. Okay, so there's some homologs between men and women. And so we've kind of talked about how that they're really similar. But here are actually like what it is in a man. So in lab, for example, they could label something and said, what is the homolog in a male? Like they could label it on a female. But they could also easily ask that in a like second or third order style question on the exam. So knowing these, what each one are, and like some have the same name, so that's easier. So glans clitoris in a female is the glans penis in a male. And they're kind of located like in similar areas. So corpus cavernosus, so if we cut this, we can see right here corpus cavernosus, and if a cross section of the penis, it's also on both sides, and that's that corpus cavernosus. The bulb of the vestibule is located right here, and that's going to be the corpus spongiosum from the bulb in the male. So here is our bulbourethral gland, and here it's coming up, and here is our corpus spongiosum. Labia minora is the ventral penile raphe. Minora. Labia majora is the scrotum in men. Ovarian and round ligaments would be like the gubernaculum testes in men. Uterus and vagina in females will be the prostatic utricle pouch in men, and this is derived from the paramesonephric duct. So there's some embryo. So know these homologs. Okay, so ligaments. We've talked about some. Here are some more that go along with our bladder. So the pubovestibular vestical ligament is going right around the vestical neck. It's continuous with the detrusor muscle, and it's helping open up that vestical neck. The puboprostatic ligament right here in men, it is lateral to that pubovestical ligament in men, and from the superior fascia of the pelvic diaphragm. It's containing that urethral support for urinary continence. So right here's the prostate. Here again is just a review slide on the ligaments that we've already talked about in women. And here's some more that we haven't talked about. So our broad ligament, we've talked a little bit about this, but you need to know just a little bit more about it, knowing the parts. So there's 3 parts. There's mesosalpinx, mesovarium, and mesometrium. So salpinx means tube. So it's going to be right beside the tube. So the fallopian tube or uterine tube, as it's called in anatomy. Fallopian is actually sort of an older name. Mesovarium is going to be like vary. That's like ovary. So ovary. So mesovarium is going to be covering that ovarian ligament, which is right here. And then the mesometrium, it's sort of like everything else. Like the most of the meat, the metrium. From the lateral pelvic wall to the body of the uterus. So here's our endometrium. Here's our myometrium. The fornix, our lateral fornix, are on either side of the cervix. Here's our cervix. Anterior fornix is in the front. Posterior, of course, in the back. The internal os is inside, going to our uterus. On the outside is going to be the external os, and that's what they're looking at when they're doing like a pap smear or a pelvic exam. Of the fallopian tubes or uterine tubes, there is going to be the ampulla. That's where fertilization takes place. Then infundibulum as it goes down, and then the fimbriae are like the fingers. Okay. Uterus position. So normally it's anteverted, anta meaning forward, and then retroverted is not usual or as usual, and that's going back. Normally, here we've got this anteverted, but with uterine prolapse, it's when the uterus sags into the vagina due to a weakness in the muscles or the ligaments. Tubal ligation and vasectomies are ways that can prevent pregnancy from taking place. It's really important to note that even if somebody has a tubal ligation or vasectomy, it's important to tell them that, and I know you've not got to micro yet, but this may prevent pregnancy, but it's not going to prevent against sexually transmitted infections. So use of a condom would be important. So tubal ligation, there's different ways that they can do this. They can take part of the uterine fallopian tube out and sew it together. They can just take a section and then sew it within the mesosalpinx. They can do some cautery where they fry that little section. They can do a clip. There's just different ways. Then also a vasectomy, that's in men, and that's where they cut the ductus deferens. Okay, external genitalia. All of this is labeled for you. You have another picture. I just put a box over it since this is going to be on YouTube, of the actual genitalia. But anyways. Okay, urinary tract. So really easy question that they could ask. Just make sure that you know that female urethra is shorter than males because so they're more likely to get a UTI. Because the bacteria have a shorter distance to travel up to the bladder, so it's really easy for females to get a UTI. Males, they're going to actually have 4 parts of the urethra. There's pre-prostatic, so before the prostate, the prostatic, the membranous, and then the spongy urethra. So the pre-prostatic is going to contain the internal urethral sphincter. So that's going to prevent that retrograde flow of the semen into the bladder during ejaculation. So you don't want any of that semen getting up there. The prostatic urethra going straight in, through the prostate. There is the seminal colliculus, but what's more important is the prostate sinuses, and I would take note of what the prostate sinus is. It's where the prostate ejects that prostatic fluid via the ejaculatory ducts. So I would know what prostatic sinus was. The membranous portion is going to contain the external urethral sphincter. That's that voluntary control of our bladder. It's the narrowest part, and it goes through that UG diaphragm in that deep space. The spongy urethra is going through the UG diaphragm in the superficial space. Okay, so we've got some accessory glands. So there are 4 lobes of the prostate: anterior, medial, lateral, and posterior. Posterior is what is during a rectal exam, when men get that, the doctor puts a finger in the rectum and says to the male, okay, when I get to a 6 o'clock position, if you feel any pain or tenderness, please let me know. And also if it's enlarged, they would be able to also feel that. It's good to know that because it's the most common part of where prostate cancer is located. So it's kind of lucky because that's the only one that you can really palpate. Also, I wouldn't just study about the posterior for histology. I would probably know something else about the anterior, medial, or lateral if I were you. Hint, hint, wink, wink. But it's not as important for MGA. Okay, so the ductus deferens, it's also called the vas deferens. It's going to be passing over those epigastric vessels and the ureter. So in females, we've got the uterine artery passing over the ureter. And so they both look like tubes. They're the same color, and it's hard to know what is what, but we know the artery is going to be passing over the ureter, so it's called the water under the bridge. So water is the ureter, bridge is going to be, in females, the uterine artery. In males, it's the ductus deferens. So if on the practical you see like 2 tubes and they label the one on top, just figure out, okay, is this a male or a female? And then you're like, okay, it's a vas deferens or ductus deferens. It's like a super easy question, and it's really important for you to know, so they're definitely going to label that in the practical. So it's going to travel through that inguinal canal, and it's going to join with the ejaculatory duct in the prostate. So these accessory glands and what they secrete. This isn't as important for MGA, but it's really important to know what they secrete for histology. So I would like make sure you know each of these. This is, in histology, you learn a few more things that each of these secrete. So like galactose, for example. So I would just make sure that you look over your histology slides and know what each of them secrete. But from anatomy, the seminal vesicles secrete fructose. So fructose-rich seminal fluid. The prostate, it's going to secrete acidic prostatic fluid. And then bulbourethral glands or Cowper's glands, they're going to secrete an alkaline mucus. So alkaline is basic. So I think basic, B, and then bulbourethral, they both start with a B. And you just like be able to find all of this stuff in the lab as well, of course. Okay, testicular ductal system. So just be able to know what the path of sperm is. You need to know this for MGA as well as for histology. So we're going to start with the seminiferous tubules, and we're going to go out through the rete testes to the efferent ductules, out to, here's the efferent ductules, to the epididymis, and down from the head to the body to the tail, and out through the ductus deferens. Then to the prostatic urethra, membranous urethra, and spongy urethra. Make sure you remember fluid from the seminal vesicles and prostate gland go through the prostatic urethra, and fluid from the bulbourethral glands goes through the spongy urethra. The capsule of the testicle is the tunica albuginea. And then the outside layer is the tunica vaginalis. So be able to know the difference between those two, because that could easily be a question. Okay. Fascial layers. A lot of people confuse some of these abdominal wall layers and what they become in the scrotum. So this is like pretty like easy. Like I would think they would ask that question, because like if people get confused or the names are very similar, they just like asking those types of questions. So I could almost promise you a question. So I'm going to start over here at like what people miss, and then I'm going to go through them all. So we've got external oblique muscles, and then we've got our internal oblique, and then transversalis fascia, or our transverse oblique muscles. So remember, this is external, and then we get more internal. So the external oblique muscle, in the scrotum, it's going to be the external spermatic fascia. But then our next layer, our internal oblique muscle, it's going to become the cremaster muscle as well as the fascia. So it's not called internal. Remember, the middle one is going to be cremaster. And then the innermost layer of the abdomen was our transversalis, but that is going to be the internal spermatic fascia. So where people get confused is they think, well, external and external, but like are the same. But internal oblique does not go with internal spermatic. So just make sure you like do not get those confused. So that dartos muscle in the scrotum was the scarpus fascia in, remember scarp out, camp in, or camp out, scarp in, I'm sorry. That is going to be the abdominal layer, and that's that dartos. It's smooth muscle in the scrotum, but it looks wrinkled. We've talked about this. It has the buccal fascia and the penis and the external spermatic fascia. Remember, the cremaster muscle is for temperature regulation. So if like the scrotum and the testes get too cold, that cremaster muscle is going to pull them up toward the body. And then tunica vaginalis is the peritoneum, or processus vaginalis in the abdomen. If the processus vaginalis doesn't close, it's going to become a patent processus vaginalis. Hematocele, heme means blood, so accumulation of blood in the tunica vaginalis, where a hydrocele, hydro means water, so that's going to be accumulation of serous fluid. And there's a potential for an indirect inguinal hernia. Make sure you know these lymph pathways. I put some more notes in the notes section at the bottom. But know that the internal iliac and the external iliac are going to drain into these lumbar para-aortic nodes. And then everything else is going to be draining into the internal iliac. So the way I kind of remember it is everything that's internal, all of the internal structures. So, for example, like ureter, bladder, seminal glands, ductus deferens, intermediate spongy urethra, and then also the cervix, the uterus, the upper vagina, all of that are going to be draining into the lumbar para-aortic nodes. Also, like our ovaries, fundus, testicles, all of that is going to be in the lumbar nodes. Everything else, the more external things like glands, penis, glands, clitoris, anal canal, rectum, lower vagina, all of that is going to be going into the internal iliac. So all the outside stuff's going internal iliac. All of the major inside stuff is going lumbar para-aortic. Okay, pelvic dermatomes. Know that the peritoneum is going to be S4, anus is going to be S5, but just make sure you review over those. Our last slide is going to be all of the structures exiting the pelvis. So we've already talked about some of these. The greater sciatic foramen above piriformis is going to be the superior gluteal nerve, artery, and vein. Going below that is going to be the inferior gluteal artery, nerve, and vein, as well as the sciatic nerves coming out of there. The pudendal nerve and the internal pudendal artery and vein are going to exit that greater sciatic foramen, but they're coming back in the lesser sciatic foramen right here. And number 3. Nerve 2 obturator internus and quadratus femoris, as well as posterior femoral cutaneous nerve, are also coming out of the greater sciatic foramen below the piriformis. Obturator canal is getting all of the obturator, artery, nerve, and vein. Above this pelvic brim is going to be the superior rectal artery, gonadal artery, and our ureters. And then this gap under that inguinal ligament is going to be the femoral artery and vein, as well as the genitofemoral nerve and the lateral cutaneous nerve of the thigh. And that's it. So if you have any questions, please email me, shoot me a message on Facebook, anything. If you need to get with me and talk about something, that's totally fine as well. And good luck with your studies. I'll be covering the thigh and I think thigh to the knee next week. So everything that you guys covered this week is what I'm going to be going over next Friday. See you.